As I said, I'm going to give a teaching presentation on HIV in critical care. Um, as I said, we've had a spate of patients in really primarily with HIV and TB on the unit. So I just thought it was something that would be quite good to look into and bring through to teaching. So what we're going to look at is what is HIV. I mean, I was hoping there'd be more sort of very junior people in the room, in which case it's a very brief look at the pathophysiology as well of the infection, and reasons for admission to intensive care and subsequent management. And then just kind of a quick look at antiretroviral therapy, not going into huge amounts of detail with the pharmacology, but looking at sort of basic principles at managing a patient on combination antiretroviral therapy or previously HAART, which is highly active antiretroviral therapy. And a little bit of a look at IRIS, which is immune reconstitution inflammatory syndrome, which is sort of terms that are kind of bandied about when patients are admitted with HIV, but it's never entirely clear and unless you know what they mean. So in terms of what is HIV, so HIV is obviously a human immunodeficiency virus. It's two species of lentivirus, which is a type of retrovirus. So retrovirus is RNA strand that is an RNA strand, and then infects a cell, activates reverse transcriptase, and that's what encodes it into the cell genome. There are two subtypes. There's HIV-1. Now, HIV-1 is globally distributed, and it's much more infectious, and generally accounts for about 95 to 96% of the cases worldwide. And HIV-2 is distributed largely in West Africa, and it's meant to be less infectious, and actually, as a result, and has more of a chronic course than HIV-1 and leads to less severe infection. I think for the sake of argument, when we talk about HIV and particularly HIV progressing to AIDS, it's mainly in the context of HIV-1. Now, it's still a major public health challenge, and it's responsible for about 630,000 deaths last year alone, and that's worldwide. And globally, it's the fourth highest cause of death, sort of worldwide again. Now, if we think about specifically HIV in the UK, there's currently 94,000 people receiving HIV care. Now, those 94,000 are at various stages of their journey with the disease. And by far, the biggest proportion of patients with HIV are in England, and actually, majority of those cases are focused around London. So as I was saying, the vast majority of patients receiving HIV care in the UK are infected through sexual transmission. And actually, contrary to typical stereotypes, the proportion of patients receiving HIV or being infected with HIV through heterosexual contact is slightly higher than through any other group, so MSM or sex workers or whatever. And actually, less than 2% are infected via IV drug use. So it really is a disease that is spread through sexual contact, but just obviously because the stereotypes exist from the 80s, just because someone is straight doesn't necessarily mean that they can't be infected with HIV through heterosexual contact. In the East Midlands region alone, around 5,162 patients are currently receiving HIV or received HIV care last year. Now, those are cases that we know about, and the concern is, as I said, because the vast majority of cases are spread through heterosexual contact, there's probably a huge pool of patients that we don't know about who are living with the virus and are unaware. And that's why we work on the basis of any patient who's admitted to the intensive care unit should be tested for or have a full blood-borne virus screen, particularly for HIV, because you want to make sure that you expose that pool and ultimately get these patients on treatment. So in terms of a brief look at the pathophysiology, so I'm not going to go into a huge amount of detail with it, just sort of the headlines. So in your immune system, you've got your innate and your adaptive immune system. Um, so CD4 T cells are, or commonly known as CD4 helper cells, or CD4 helper T cells. And they're important cells in the adaptive immune system, so adapting to new infections that you're being infected with and developing memory for those infections. They work by activating memory B cells, and that promotes a much stronger immune response, an antibody response to pathogens than specifically the innate system utilizing CD8 positive cells or cytotoxic T cells. Now, HIV specifically infects CD4 positive helper T cells. Now, that ultimately depletes their numbers and cascades further virus release into the bloodstream, and then further infection and further depletion of numbers of T cells. And that gradually weakens the immune system and increases the risk of opportunistic infections, so infections that we normally wouldn't be, a normal immunocompetent person wouldn't be infected with. Now, the WHO classifies HIV, and this is a typical Fickham type question, which is the categorization of HIV. Now, it looks at primary HIV infection, and that may be asymptomatic or associated with acute retroviral syndrome. So acute retroviral syndrome is kind of like a flu-like illness that occurs following HIV infection about 8 weeks afterwards. The reason why you get this kind of griping fever and sort of constitutionally flu illness is because you get a very rapid increase in your CD4 or in your viral load in that initial infection term. Now, ultimately, that activates not only your innate immune system, causing activation of CD8 positive T cells, which are your cytotoxic T cells, which very rapidly suppresses the virus. So the reason why you have that latency period after that initial flu-like illness is because you very rapidly suppress the virus with CD8 positive T cells. And that's why you get your latency from. Now, as part of that latent period, stage one is, it looks at your CD4 count. So stage one is when your CD4 count is greater than 500 per microliter, and that may be asymptomatic, or it may lead to generalized lymphadenopathy. Stage two is mild symptoms, and that's sort of mucocutaneous manifestations and sort of recurrent griping infections, recurrent respiratory tract infections. As you get into stage three, and as your CD4 count drops even further, you get advanced symptoms, and that kind of includes things like chronic diarrhea, severe bacterial infections, and renal failure through a condition called HIV-associated nephropathy or HIVAN, which is kind of a group of causes of renal failure in the context of HIV infection. As the disease progresses further, however, you can develop stage 4 infection or AIDS, which is where your CD4 count drops lower than 200, and that's a key number, and you have an AIDS-defining illness. So it's a low CD4 count plus a typical defined illness. Now, if we look at the AIDS-defining illnesses, I thought this was a nice picture that kind of sums it up. They're a huge number. So primarily, we see neurological and pulmonary disease. And I'll go into the ones that affect us in ICU in a little bit more detail shortly. But just sort of features of very severe HIV infection itself leading to disease separate from AIDS can be things like dementia or meningitis or encephalitis. Although this mentions that it's an AIDS-defining illness, HIV-associated encephalitis isn't, strictly speaking, an AIDS-defining illness because it can occur with higher CD4 counts as well. The sort of the biggest ones, however, are things like toxoplasmosis, which is the T. gondii, and cryptococcus within the brain, which we'll go into, and then things like tuberculosis and fungal disease in the lungs again, which we'll go into as they're common causes for admission to intensive care. Just as a note, cancers, specifically things like lymphoma, perineal SCC, things like Kaposi sarcoma, are also prevalent in patients with very low CD4 counts. Um, and similarly, in patients who've got severe HIV infection, you can get quite bad HLH or mast cell activation syndromes, which may sort of present looking like sepsis, but is actually a feature of severe disease itself. So kind of looking into why patients with HIV present to ICU. So why are we bothered? Well, we're in a centre with an in sort of big migrant population that we serve, with a tertiary or at times quaternary referral centre for infectious diseases. So these are patients that we should see regularly coming through the unit. Now, there's a recent shift in reasons why patients present to critical care with HIV. So traditionally, it used to be patients coming in with AIDS and opportunistic infection. However, it's no longer just that. And it's particularly as antiretroviral therapy becomes more advanced and more patients are living with AIDS or living with HIV, sorry, rather than coming in as a result of severe HIV and AIDS. So we're seeing an increasing incidence of patients with comorbidities accelerated by HIV. And these are things like ischemic heart disease and renal disease and cerebrovascular disease. All three of these are massive. The risk of all three of these are massively increased by concurrent HIV infection. Similarly, we also need to be aware of the challenges of managing patients on combination antiretroviral therapy with other disease progressions as well. And I'll go into why that's important on a subsequent slide. I mean, ultimately, the most common cause for admission is bacterial infection and sepsis. And these patients will have often had recurrent infections. So we also need to be aware of antibiotic resistance due to recurrent antibiotic use. So when we look at respiratory disease, community-acquired pneumonia and respiratory failure are by far the most common respiratory disease. And it's normally our standard pathogens, things like strep pneumoniae. However, we also need to think about other pathogens like things like Pseudomonas, as they're less immune competent. And typically, as your immunocompetence drops, you increase your risk of other atypical infection as well. So that all needs to be sort of bear in mind. And those are things like chlamydial pneumonia. Now, one of the things that we've seen a couple of cases of is TB, particularly miliary TB, which is sort of very advanced TB within the lungs, which forms small little balls of TB called milia, and they can spread throughout the body. And that's responsible for about 20% of cases of respiratory failure with HIV. Now, diagnosis is via sputum. Now, you may have heard people talk about being smear positive or smear negative for patients who come in with TB. Basically, what that means is they take a sample of your sputum, they smear it on a microscope slide, and then they have a look at it under the microscope. If they see acid-fast bacteria, then you're smear positive. If they don't, then you're smear negative. The reason why it makes a difference is because if you're smear positive, you're massively more infectious than someone who's smear negative. And then you may also hear about things like the Gene Expert assay or TB Gene Expert, which is a PCR test. So it's treated with anti-TB medication, and that includes things like rifampicin, isoniazid, ethambutol, and pyrazinamide. Again, in very resistant or for very resistant organisms, there are other drugs like high-dose meropenem and things like that you can add in. But that will all be led by the infectious diseases team. And you've also got to consider distal spread in someone who's got very, very profound miliary TB or severe TB pneumonia. And that includes things like CNS infections. So anyone who comes in with respiratory failure and altered sensorium should largely have an MRI scan. So CT is not particularly sensitive for picking up TB meningitis or TB encephalitis. So an MRI scan would be the gold standard of diagnosis there. In terms of other respiratory disease, so pneumocystis jirovecii, which used to be pneumocystis carinii, is a fungal type of pneumonia. So it's a classical triad of worsening dyspnea, dry cough, and a high fever, again in the context of a very low CD4 count. Now, often these patients compensate for a really long period of time before they then very acutely deteriorate. And I'll show you one of the x-rays. Actually, you may see x-ray appearances which look like very severe disease, but actually the only feature that you have is the classical feature of desaturation on exercise. So you may, the point is we may see these patients very late once they've decompensated. So diagnosis is via bronchoalveolar lavage and culture. And treatment would be antifungal medication like clotrimazole or Septrin. Now, that's in combination, with steroid cover, and steroids have been shown to significantly reduce the duration of ventilation and overall. So another reason why patients with HIV present to and AIDS present to ICU is through CNS infection. So, and again, these are sort of standard things like meningitis from our standard pathogens. But there are specific conditions which are associated with AIDS itself. So toxoplasmosis is caused by Toxoplasmosis gondii. It's a parasitic protozoan, and it usually presents with altered sensorium and seizures. So we may well be called down to places like ACB or to IDU for a patient in status epilepticus. Now, the MRI scan for these patients shows a really typical ring-enhancing lesion with very, very significant cerebral edema. And treatment, again, is a combination of pyrimethamine and sulfadiazine for up to 6 weeks. And if I show you a MRI scan of typical CNS disease, is things like cryptococcal disease. So cryptococcal meningitis is a fungal meningitis, and it presents subtly differently to acute bacterial meningitis. So they get kind of a low-grade griping fever with a worsening headache and visual symptoms, and then it progresses to a cognitive deficit. Again, the main issue with cryptococcal meningitis is that it causes a massively increased intracranial pressure. The problem with that is you'll see a patient with sort of slightly altered sensorium and cognitive deficit via lumbar puncture, and I know we've got to be really careful when it comes to patients with high intracranial pressure and lumbar puncture, but I had a chat to some of the ID physicians, and they would still advocate in order to get a fix or in order to get a solid fix to the diagnosis. And what you would see is a normal glucose, a moderately raised protein, and really high white cells and lymphocytosis to keep their intracranial pressure manageable. And then there are other CNS features of HIV, and those can include things like encephalitis, primarily from HIV itself, causing inflammation within the brain parenchyma, and then viruses such as CMV, causing retinitis, nephropathy, and other things like esophagitis. And again, as I mentioned before, we've always got to keep an eye out for TB meningitis, particularly in the context of someone who's come in with TB resulting in respiratory failure in the context of HIV. Now, I just wanted to look very, very briefly at the treatment of HIV. So previously it was called highly active antiretroviral therapy, or HAART, but now actually that's been taken over by combination antiretroviral therapy. So you may see it written as CART. And there are 4 types of antiretroviral drugs. So there's nucleoside reverse transcriptase inhibitors, and they interrupt the transcription from viral RNA into actual DNA. You've got the non-nucleoside reverse transcriptase inhibitors, again, which does a similar sort of thing on a different enzyme. You've got protease inhibitors, which stops the production of new viruses, and then you've got integrase inhibitors that stops the DNA that's been produced from reverse transcriptase in the viral RNA being integrated into the CD4 cell nucleus and nucleic DNA. Now, in terms of how patients are managed on antiretroviral therapy, as I mentioned before, we're seeing more patients coming in with chronic HIV on treatment than with real sort of complications as a result of HIV. So antiretroviral therapy should be continued on all patients known to have HIV. The problem with antiretroviral therapy is that it's all in enteral form and there are no IV forms that exist at the moment. And the main issue with that is that if you have frequent interruptions in treatment, it can lead to resistance, the virus evolving to be resistant to that antiretroviral therapy. Now, that can be overcome once the actual critical illness is overcome if it's an isolated episode. But there does need to be care taken when there are frequent admissions to ICU. Now, what I wanted to look at very briefly as well is immune reconstitution inflammatory syndrome, or IRIS. So the decision on when to actually commence antiretroviral therapy is often quite complex, and occasionally looks like it doesn't really follow a specific pattern. Risk factors for IRIS are having a really high viral load and a really low CD4 count. So the more CD4 counts you very rapidly restore, the more inflammation you get, the more likely you. I've not gone into a huge amount of detail just because there's kind of a mix of level of training in the room, and also it gets boring. But if anyone's got any questions, just give us a shout.
No, if they miss their meds because they're intubated, how time consuming is it to get?
Yeah, so this is the thing, and it kind of is how long is a piece of string. I think if it's an isolated episode of critical illness, then I think you'll probably be okay having an interruption in therapy for as long as you need it, really. I think the problem comes when you've got patients who are bouncing in and out of hospital, and in patients who are generally not hugely compliant, because that's when you're going to get really treatment resistant strains of the virus being produced. And that's where we can run into problems like IRIS, because these patients will have really resistant high viral loads and probably really low CD4 counts, despite being on therapy. So you kind of get lulled into this false sense of security that they're going to be fine when you reinstitute treatment. But obviously it then leads to complications like an IRIS, even though they're already on therapy. But again, that's why having an early ID involvement is really key. And sometimes they say they're not really going to do anything, which is fine. But actually, the reason why it's worth having them involved is for that circumstance, well, for sort of the medium providers with appropriate advice.
Hi, Anish made my job a lot easier. This is in correlation with his topic. So this today's topic was an article which was published last month, adjunctive dexamethasone for TB meningitis in HIV positive adults. And this particular study is important because TB meningitis is a serious complication which is caused by tuberculosis, and this condition is very commonly found in HIV positive patients, and mortality can exceed more than 50% in whoever has HIV. And there were two studies done prior to this one. These were landmark studies in 2004, which involved this study was done in Vietnam and Indonesia, and the prior two different studies that I'm going to show now were also done by the same group and in the same place, 2004 and 2016, and they concluded this particular 2004 study concluded that an adjunctive corticosteroid therapy in these patients improved mortality. But in 2016, this particular systematic review from India, it concluded that there was no benefit, neither any improvement. But regarding all of that, despite that, we have been having corticosteroid therapy as a mainstay of treatment in patients having TB meningitis and HIV-related patients as well, in the 2020 WHO guideline as well as the CID guidelines. They hypothesized that adjunctive dexamethasone will reduce the risk of TB, will reduce the risk of death from TB meningitis in HIV co-infected adults. And they had a lot of secondary hypotheses as well, uh, which I'll talk about it later. And they included anyone who was above the age of 18 who were HIV positive, newly or previously diagnosed, who have received the clinical diagnosis of TB meningitis for more than 5 days, and in whom anti-tubercular chemotherapy was either planned or already has been started. They excluded patients who were ineligible with another brain infection if the ATT was started more than 6 days ago, and if they were already receiving corticosteroids, and if they were contraindicated for corticosteroids, they were excluded. This was the two schemes. I'll talk about the MRC grading in the next slide, and they differentiated these two. All the patients who were in the study group received steroids for either 6 weeks or 8 weeks, and the MRC grading was GCS score of 15 with no focal neurological deficit, grade 2 and 3 having some neurological deficit with a low GCS score. The objectives were as death primary, and the secondary were neurological disability at 12 months, IRS, as Anish had already talked about during the first 6 months, and several other endpoints after 1 year of randomization. First neurological event or death, new AIDS defining event or death, HIV associated cancer. Kaposi sarcoma is really commonly seen in patients having HIV, and use of any open label glucocorticoid treatment for any reason if the patient had any shunt surgery sequelae later on. So this was the protocol. They included anyone who was with suspected TB or who had a diagnosis of TB meningitis, or any adult above the age of 18, HIV test positive, less than 4 days of steroids, less than 7 days of ATT, and they considered taking 520 patients. I'll talk about this as well. And they divided into two groups, one receiving dexamethasone, one receiving placebo. And they monitored for any drug-related liver injury. Although this study did not include this DILI, this will probably come up in the next study that they have included or studied together. And assessments were these patients, participants underwent clinical assessment at baseline, the day 0, then 3, 7, 10, 14, 21, and every month till the month of 12. GCS, MRC grading, and details were noted. Baseline blood investigations, renal function test, liver function test, CD4 count, HIV viral load, all of these were taken out. The analysis was done based on the prior trials of 2004 and 16. They assumed that a target hazard ratio of death in the previous trial was 0.69, that is 2004, and a 9th-month mortality of 40%. So what I want to point out is hazard ratio is nothing but if you have a hazard ratio of 1, that is if you're having any drug-related event, it would be equal in the patient who is receiving a placebo or a drug. If it is, say, suppose 1.5, so 50% chances of having a drug-related event more than having a patient under having a placebo. Or if it is 0.5, which is beneficial, so 50% less event in a patient receiving the drug than the patient receiving placebo. So 0.69 is obviously on the beneficial side, and we'll see how this does. They estimated that about 520 patients will be required to have a power ratio of 80% and a two-sided significance of 5% with an allowance of 5% to follow up. Analysis was done. I'll talk about it. The primary analysis was a Cox proportional hazard regression model because a lot of covariants and cofactors were included. So that is why they used that. And the secondary endpoints were compared with the use of Cox proportional hazard model again. The number of participants with any serious event was compared by the means of chi-square test. And the data was analyzed in R software. This was the consort flow chart. 779 persons were eligible, assessed for eligibility, and 520 were randomized. 263 were assigned to receive dexamethasone, and 257 were assigned to receive placebo. The good thing is that they had a very less number of dropouts, and at the end they had 249 patients in per protocol basis, and 238 in the other group. So that's good. Baseline characteristics were comparable in both. What I've maybe this screen is too small to see, so I've just noted the important points on the right. So the median age was about 36 years of age. Most of the patients had mild or moderate diseases with respect to TB, meningitis, mild or moderate, with a grade 1 or grade 2 disease. And out of them, 186 had newly diagnosed HIV. The point to be noted is that 251 out of 484 patients had CD4 count of less than 50. So this is very severe. This was probably one of the factors that will affect this later on. Coming to the endpoints and the observation, death, the primary endpoint was that there was no benefit seen in the patients receiving dexamethasone. Out of 263 participants in the dexamethasone, 116 had death, and which was about 44.1%, and 126 in 257 participants, 49% in the placebo group. And talking about the IRS, there was a little bit of more IRS seen in patients receiving dexamethasone, but it was not significant. The hazard ratio was just above 1.1, but this was not statistically significant. And coming to secondary endpoints, looking at the MRC grading and the diagnostic criteria, the anti-tubercular drug resistance, they were all same in both the intention to treat and the per protocol population. In the dexamethasone group, the similar likelihood of IRS was seen. No neurological death or event was also, it was same in both the groups. There was no benefit of dexamethasone in any subgroup analysis as well later on. They looked at all of the different scenarios of events, hepatobiliary, respiratory, metabolism, infection, secondary infections, vascular disorders. They were all approximately the same. And this is the combined and any serious adverse event. So it was 73% in the dexamethasone and 75% in the placebo group. So they concluded that they were unable to confirm a benefit of any dexamethasone therapy on HIV positive adults with TB meningitis with respect to survival or any secondary endpoint. And the planned subgroup analysis did not identify any subpopulation that was clearly benefited from this. The incidence of serious adverse events was also similar in both the groups as we just discussed. Coming to limitations, they have pointed out a limitation that the effect size was observed as 0.85. This was their study, which was less than anticipated. The 2004 study had a hazard ratio of 0.69. So this was probably more. And although it was similar to that in the 2016 study, which showed 0.86. Secondary, 138 participants were given open label steroids at some time during the treatment, and the additional glucocorticoid may have obscured the outcomes between the two groups. So the patients in so this was pragmatic actually. I wouldn't say this was a limitation. This was very pragmatic for them to give any open label corticosteroid given the condition of the patients. Thirdly, the findings may not be generalizable to better resource settings because a lot of patients who were supposed to get a VP shunt were delayed in their resource setting. So this might be a big cause why they had so many deaths in 12 months. The strength was that it examined, this is the largest number of patients that they have taken so far, and they examined steroid exclusively in HIV positive adults with TB meningitis. And probably 5 times more than any other study done prior. They were very pragmatic, as we already know. And finally, the trial had high retention and only 5 patients were lost to follow up. So this was a very big strength. The questions that I think was the only one that all of the patients, most of the patients, more than 50% of the patient had CD4 count of less than 50, which was probably this may have caused some or the other issue in getting the results as desired. These patients were already at a risk of opportunistic infection, which might have altered the effect of dexamethasone and increased the risk of adverse events. Thank you. Anish, any points?
No, I think that was good. Like you said, I think the main thing is also teasing out, because just picking up on that point about iris in the context of TB. ID physicians use like so many different terms for basically what is the same condition. So things like paradoxical reaction and iris are kind of all part of the same sort of syndrome, but they're just sort of subtly different. So again, that's why it's really important to just make sure you're teasing out what the ID team actually mean when they're saying stuff and asking you to give stuff, because it occasionally means things that are completely different to what it sounds like, and sometimes they say lots of different things in the same way.
The thing that I wanted to probably understand from this is a very big study that they have undergone, and this was the statistics was done by the Oxford University here in UK, and the study was done in Indonesia. I don't know how they did that. The study was spanning over 5 years, 2017 to 2020, I think 3 years. And they took in about 500 patients. And this was also a study which was funded by the Wellcome Group from the UK as well. The primary investigator was won a grant in 2017, and post which they have revised this protocol 3 times before they conducted this study. So, which was supposed to start in 2017, started around a little late in 2018. And a lot of covariants and a lot of cofactors, confounding factors came in between to get something. And probably this is the best one can actually get from this. I don't think so. We have any other study which spans HIV positive TB meningitis, more than 500 patients.
Yeah, so it's a pretty niche study. I think to be perfectly honest with you, from experience, despite what kind of a lot of evidence shows, the way in which these patients are managed kind of varies from physician to physician, or infectious disease physician to infectious disease physician. So some will advocate for steroids, some won't. Some will give dexamethasone, some will say give methylpred. So and I think it's one of the reasons why it's really important to get ID involvement quite early on, because as I said, you want to make sure that you've got a clear direction in which you're moving, particularly in ICU, where we're not used to dealing with sort of patients with multiple complex things going on at the same time.
And when you go through the 210 pages of the protocol that they have said, these patients had a lot of neurological issues later on at, I think, 4 or 5 months into the disease process. But a lot of times they were delayed for an MRI, and the VP shunt was even further delayed. So they had a lot of deaths due to high raised intracranial pressure as well. That was equal in both the groups, but don't know if that made a difference. As you said, the MRI is the only way you can look at it, and it takes a lot of time, and a CT scan would have sufficed.
Yeah, and I think, to be honest with you, like particularly with TB meningitis,
Mm.
if it's severe enough that you're on ICU with severe CNS infection, um, then you're going to probably trying to get that imaging is always going to be really difficult to assess disease progression. Um, so again, which is why everything is kind of done a little bit off the cuff, and it always feels like it's sort of made up a little bit. But as I said, that's why it's important that we just kind of do our organ support bit, and then we let the ID physicians do the rest, just because there are so many varying opinions on what the best way forward is that actually is best under these circumstances in the context of very severe HIV, to make sure that you've got early involvement.